Hello, and welcome to this three-part training series. We are going to talk about the 5 secrets to treating myofunctional disorders with confidence. What do we need to do and to know in order to treat with confidence? Number 1, understand orofacial myofunctional disorders. And this lesson is going to focus on understanding orofacial myofunctional disorders. Then in the next lesson, we're going to discuss screening for orofacial myofunctional disorders. The final lesson is going to be about treatment and what myofunctional therapy is. So what are the 5 secrets? Understanding our orofacial myofunctional disorders, evaluating properly, collaborating with other professionals, doing our treatment properly, and the final step is to help our patients habituate the skills and use them daily without even thinking about those skills. And we're going to discuss the goals of myofunctional therapy. Just a little hint, it's not the exercises. My name is Dina Zagwi. I'm a speech language pathologist, orofacial myofunctional specialist. Some people like to call themselves myofunctional therapists. I sometimes refer to myself on social media. I'll refer to myself as a myofunctional therapist, but to be honest, myofunctional therapy is not a standalone profession. So my profession is SLP, speech language pathology. My specialty is in feeding therapy as well as myofunctional therapy. I'm so glad you're here and so excited to share some of my expertise with you here today. Before we begin talking about orofacial myofunctional disorders, let's take a minute and talk about orofacial myofunctional health. So let's break down the word orofacial, orofacial myofunctional. Oro means mouth, facial means face, myo means muscle, and functional means working. So orofacial myofunctional health is about how the muscles of the face and the mouth are working optimally together to do the jobs that they're meant to do: chewing, swallowing, breathing, and speaking. If they work well together, they integrate. We have proper nasal breathing, proper rest posture, proper chewing and swallowing patterns, then we're going to have clear speech. Then we have optimal growth and development, optimal orofacial myofunctional health. Now, if something goes wrong with any of these functions, we call it an orofacial myofunctional disorder. In short, OMD. So what symptoms give us clues that an individual presents with an orofacial myofunctional disorder? Mouth breathing. Mouth breathing is like the number one thing. Now, I want to explain that mouth breathing is not necessarily a wide open mouth posture. It could be a small mouth opening. As long as some air goes in and out the mouth, that's considered mouth breathing. So, nasal breathing is exclusive, which means the lips are sealed in a relaxed position and we don't have any tension. That's the ideal nasal breathing. We do have sometimes some patients that are nasal breathers, but they're working hard to keep their lips closed. So that's another conversation. Right now we're talking about mouth breathing, and mouth breathing means the lips are apart. Okay, what else gives us an indication? Low tongue rest posture. Now, sometimes we have patients who are nasal breathers, but the tongue is still resting low in the mouth. And that's why we need to ask our patients, where did your tongue rest when you're not using your mouth to chew, swallow, talk, drink, sing, any of the mouth functions? And they will tell us. Very young children don't really know, but school-age children, adults will tell us exactly where their tongue is resting. So what I want to say is that nasal breathing does not necessarily mean your tongue is resting in the roof of the mouth. And we're going to discuss proper tongue rest posture. Drooling, excessive drooling. We see that with 3, 4, sometimes even 5-year-olds. This is way beyond the age of teething. When babies are teething, that's very normal part of the teething time or time period. But if it's beyond that, then we're going to see drooling sometimes, and that happens because sometimes children forget to close their lips and swallow. They have their mouth breathing, and so a lot of saliva comes out. Sometimes with enlarged adenoids is excessive saliva. Reflux, Dental malocclusions, any type of malocclusion, whether it's an open bite, an overjet, underbite, crowding, any of those are an indication that there's an orofacial myofunctional disorder. Prolonged articulation deficits. If you're an SLP and you're treating a child for a specific articulation error, whether it's a lisp or R distortions, for more than 6 months and you haven't had success, or if you're treating a child for longer and they're not carrying over to conversation, then that's an indication of a possible OMD. And tongue thrust swallow, and we're going to discuss what a tongue thrust is. So when you're looking at your children, your patients, your own children, your patients, your clients, pay attention to these things. These are red flags to sleep disorder breathing. And one more thing I want to add, if they're thumb sucking, if they're still using a pacifier, anything that promotes that tongue resting low in the mouth and lips apart, it gives us a clue that there's an orofacial myofunctional disorder. So here are the causes of OMDs. Allergies, I always list them on top because they cause many of these things, okay? Any airway obstruction, tongue tie, tongue or lip tie, and an object in the mouth, pacifier, a thumb, nail biting, biting on objects, anything that will lead to mouth breathing is going to cause an OMD. Tongue ties will lead to mouth breathing because when the tongue is tethered to the floor of the mouth, it's like a weight on the lower jaw and it will cause the mouth to remain open. So we have to always understand the root cause. And these are things that we try to understand. We're not, as a myofunctional specialist, I'm not an ENT, but I could screen for it and decide and determine whether or not I need to refer to an ENT. And we're going to discuss that when we talk about screening. Our nose is designed for breathing. The mouth was never, ever meant for breathing. If you have a cold once in a while, that's okay. You're congested, your mouth breathing. But I'm talking about more chronic mouth breathing. We're not meant to breathe through our mouth, in and out, okay? The other day I was at a personal trainer and I said to her, she told me, inhale from your nose, exhale from your mouth. And I said, we need to inhale and exhale from the nose. And she got upset at me and she says, not here. Here we do exhale through the mouth. We are not meant to breathe in or out of the mouth. The mouth is not for breathing. What happens when you're mouth breathing? Shallow breathing, upper chest breathing. You're in fight or flight mode. When you're breathing through your nose, your body is relaxed. You're in rest and digest mode. And that is what our bodies need. Okay? Mouth breathing causes dry lips. Many of our patients tell us that they're constantly applying chapstick. It causes dry mouth, which can lead to tooth decay, increased upper airway problems, altered tongue posture. Remember what we said, when the mouth is open, I actually talked about tongue tie, but let me just say it here. When the mouth is open, the tongue is going to remain on the bottom. There is no such thing as open mouth posture and tongue up. It just doesn't happen. Mouth breathing leads to low tongue rest posture. Low tongue rest posture leads to poor facial development, which leads to poor facial development and poor jaw development, which leads to poor facial development, which leads to dental crowding, crooked teeth, malocclusions of some sort, changes in body posture. What happens in the mouth impacts body posture, and what happens in the body impacts mouth posture. Mouth breathing leads to low tongue rest posture, which basically, I want to just stop here for a minute, stimulates vertical growth patterns. The tongue allows for proper development of the jaws. And so we have a nice, when the tongue rests in the roof of the mouth, the face develops nice and wide. The palate develops U-shaped, which allows for forward growth. But when we have mouth breathing, low tongue rest posture, we see more long face, vertical growth pattern. And of course, mouth breathing can impact on speech production as well as a narrow nose. So when this part, the midface, is underdeveloped, the nose appears narrow and sometimes even large. So what is oral rest posture?
Oral rest
It's the way the
posture.
tongue, lips, and the jaw rest.
So what is
when we're
oral
doing
rest posture?
nothing.
Oral rest posture.
All right? Doing nothing means we're not talking, we're not
So what
chewing, we're
is oral
swallowing.
rest posture?
And
Oral rest
what is the
posture.
ideal oral rest posture is when the
So
lips
what
are
is oral
sealed
rest
in
posture?
a very
Oral rest
relaxed position.
posture.
We don't want to see any
So
muscle
what
tension
is
around the
oral
lips.
rest posture?
The tongue
Oral rest
rests
posture.
comfortably in against the roof of the
So
mouth.
what is oral rest
Tongue,
posture?
tip of the
Oral
tongue
rest
on the spot.
posture.
Body of the tongue lightly suctioned against
So
the
what
roof of the
is
mouth.
oral rest
And
posture?
the
Oral rest
teeth
posture.
are slightly apart, 2 to 3
So what
millimeters
is
apart,
oral
so the
rest
jaw is
posture?
relaxed.
Oral rest
That's the
posture.
ideal oral rest posture. It impacts
So what
on
is oral
the
rest
way we
posture?
swallow.
Oral
It
rest
impacts,
posture.
look at that thumb. It impacts on the
So
way
what
we
is oral rest
speak.
posture? Oral rest
And
posture.
when we see children
So
with
what
low
is
tongue
oral
rest
rest posture?
mouth
Oral rest
breathing,
posture.
we typically see the
So what
phonemes
is
L,
oral
T,
rest
D, and
posture?
N
Oral rest
produced
posture.
in an interdentalized
So what is
position.
oral rest
They're
posture?
never
Oral
meant
rest
to be there.
posture.
These are the alveolars. Alveolars are produced
So what
at the tip
is
of the
oral
tongue
rest posture?
on the
Oral rest
alveolar ridge.
posture.
Okay? And very often
So
we see
what
the
is
lisp, and
oral
that
rest
lisp is
posture?
often
Oral
a
rest
symptom of
posture.
an orofacial myofunctional disorder
So
and not
what
the
is
problem.
oral
And
rest
if
posture?
it's the
Oral rest
case,
posture.
then you're going to be stuck in therapy for a long
So
time
what
without
is oral
addressing
rest
those
posture? Oral rest
underlying
posture.
issues. So what is wrong with low tongue rest posture? What's the big deal if the tongue is here and not here? Okay, the tongue is a natural palate expander and retainer of the palate. We have constant forces from the cheeks and lips. Okay, now we're talking about the tongue, but we also have forces from the lips. And when the lips are sealed and the tongue rests in the roof of the mouth, we have beautiful jaw growth and, facial development. But when the tongue rests low in the mouth, it's going to impact on the growth of the jaws. Why? Because those forces, when the tongue rests in the roof of the mouth, it counterbalances those forces. When it rests low in the mouth, the palate will collapse, and this way rather, will collapse and become high and narrow. Now, the roof of the mouth is also the floor of the nose. So when the roof of the mouth, the maxilla, the upper palate, the upper jaw, is high and narrow, it takes away space. It goes into your nose, basically, and takes away space from nasal cavity. The other thing that happens is that the lower jaw, the mandible, follows the growth of the upper jaw. So when the upper jaw develops high and narrow, the lower jaw is set back and doesn't come forward, doesn't grow forward, and it remains back and in your airway. So you end up with a narrow and pinched airway. Okay, so we need proper rest posture for proper jaw development. And most importantly, airway development. That's a tongue thrust. It's a dysfunctional swallowing pattern at which an individual, like you're seeing right here, individual pushes the tongue either between or against the teeth when swallowing. We see the tongue thrusting, the example I showed you with the tongue thrusting between the teeth. We see that with younger children. Sometimes we see older children do that. But with older children and adults, we see the engagement of the lips and the mentalis muscle. Let me demonstrate it one more time. That happens because when you don't use your tongue properly to swallow, you're going to engage surrounding muscles to be able to propel whatever you're swallowing. Now, a tongue thrust is a symptom, it's not the problem. So it's a compensation for either tongue tone, tongue tie, or breathing issues or airway obstruction. Now, tongue tone usually happens when there's a tongue tie or breathing issues. I haven't seen patients with just tongue tone issue without either obstruction or tongue tie. The only time I've seen it is when, let's say, a child had tonsils removed, but they're still mouth breathing because they never learned to nasal breathe, and that could impact on tone. Now, our job is to evaluate and see what could be causing the tongue thrusting pattern. It's not a standalone issue, it's a symptom. And when it comes to airway obstruction, that tongue and the tonsils cannot be there at the same time. It's either the tonsils or the tongue. And when the tonsils take so much airway space, we're going to bring the tongue forward to be able to breathe. And we compensate with a tongue thrust pattern Obviously, we have low tongue rest posture as well, and tongue that's pushing against the teeth at rest. So people always ask, what pushes the teeth, tongue thrust swallow or low tongue rest posture? It's the low tongue rest posture that causes the teeth to shift. Linda D'Onofrio is a legend and a queen of orofacial myology. No one understands orofacial myofunctional disorders the way she does. No one teaches about OMDs the way she does. She is my amazing mentor. I learn a lot from Linda. She was my first inspiration into orofacial myology, and this is what she says. The lips are your face's braces, and your tongue is your natural palate expander. If your lips are closed and your tongue rests in the roof of the mouth, everything develops beautifully. And now I just want to conclude this lesson by talking about oral motor challenges with clients or patients with persistent articulation deficits. These are the things that we see: poor tongue-jaw dissociation, poor lip-jaw dissociation, limited tongue mobility, tongue weakness, imprecise and uncoordinated tongue movements, poor tongue tip control. We need to have good tongue tip control for tongue tip phonemes, poor back tongue control that we need for back tongue sounds like K and G and R, jaw instability, hyper or hyposensitivity. So we're going to conclude this lesson, and the next lesson we're going to discuss how you can screen your clients or your patients for facial myofunctional disorders. Thank you so much for being here, and see you in part 2.